Hello and welcome back. This is Zubair Khanzada here with another video of mine. This time I'm going to share a complication which is unfortunately a thoracic duct injury post VATS two-stage oesophagectomy. Once we started our VATS, we looked at the conduit which looked fairly healthy in this case. And then we retracted the lung and the conduit interiorly, and then we would start carefully looking for the thoracic duct in order to ligate it at the base of the right thoracic cavity. This patient underwent two-stage oesophagectomy for a lower esophageal tumor a few days early, and during the surgery, unfortunately, the thoracic duct injury was not picked up. We had it a couple of times before this, but during the surgery we were able to pick it up and we were able to ligate. We don't ligate them routinely, as you would know, the jury is out there, and it's half of the people do ligate them and others don't. As you would remember, the famous mnemonic about the thoracic duct's location. It's the goose between the two goose, between the esophagus and the esophagus, right in front of the aorta. You can see the esophagus vein and the fat in front of the aorta, at which level we started carefully opening up the pleura in order to dissect the thoracic duct out. Um, it is a very delicate structure, and one has to take utmost care not to injure it during the dissection. Um, Excellent camera holding skills and excellent assistance are paramount in doing these technically challenging operations. And nevertheless, you need an excellent anesthetist, anesthetic team who can take the lung down and put the patient back on single lung ventilation. You can see the esophagus vein at the back, and a branch of thoracic duct has starting to appear interiorly, and we continued careful dissection to find the main thoracic duct. My practice usually is that once I have seen the thoracic duct, I tend to divide it just to see the gush of chyle coming out, which usually confirms that this is the main thoracic duct. Prior to the operation, patient was given 100 milliliters of double cream orally, which was around 6 hours prior to the operation. It usually helps to visualize the thoracic duct, and it's easier to find during surgery. So you just saw a gush of chyle coming out of the thoracic duct, following which it was ligated by clipping it. Both the upper and lower ends were ligated using the titanium clips, and the branch was also ligated. Prior to this, we did put the patient on conservative management. As you would have seen my previous videos of the VATS two-stage oesophagectomies, our routine practice in my routine practice, I do not put NG tubes in, and patient starts liquid diet from day one post-operatively. In this patient, when the patient started the liquid diet, unfortunately the chest drain volume increased, and it became evident that the patient had chyle leak. Initially we tried to treat it with totally fat-free diet. Unfortunately it was not successful, and then we did push patient on TPN, but again unfortunately it did not stop our chyle leak. So we went in by doing VATS and ligating it physically. And afterwards a chest drain was reinserted, and patient was again monitored for chyle leak, and we were extremely lucky in this case that the chyle leak was stopped. Patient went home a couple of days following the surgery. Thank you very much again for watching. Take care.